Hello, hi everyone. Today I'm back with another lecture. The topic of today's lecture is principles and practice of impression procedures. Moving on to the course objectives. The learning objectives expected from you are: first, you should be able to define what is an impression and impression trace. You should be able to categorize the preliminary impression materials and trace. You should discuss the objectives of impression making and preliminary impression techniques. You should be able to summarize the principles and theories of impression making. So, coming to impressions in complete dentures. A complete denture impression is a negative registration of the entire denture bearing, stabilizing, and border seal areas present in the edentulous mouth. That is, the denture bearing area with the peripheral borders, how it looks in the mouth, it should be exactly looking like a negative replica within the impression that you have just made. Coming to an impression tray is a receptacle into which a suitable material is placed to make an impression. An impression tray may be a stock impression tray, which may be edentulous or dentulous, or it may be a custom made impression, which is used for making the secondary or final impression. An impression tray is also a device used to carry, confine, and control an impression material while making the impression. So coming to the various preliminary impression materials, as you all know, most of you have done complete dentures or are doing complete dentures and removable partial dentures. Preliminary impression materials are impressions which are used to take first impressions or diagnostic impressions. They are broadly categorized into two crude categories. That is, they may be reversible or irreversible based upon their chemical reaction. So in irreversible preliminary impression materials, we have POP, that is plaster of Paris, zinc oxide eugenol, alginate, and elastomers. Zinc oxide eugenol is also known as irreversible hydrocolloid because it is an irreversible material. In reversible materials, we have impression compound, we have mouth temperature waxes, and agar agar. All of these are thermoplastic reversible impression materials. That is, they react to temperature, and when the temperature is raised they liquefy, and when the temperature is lowered they again turn to solids. So moving on, the most, like when here we were talking about mod temperature waxes, the most familiar or the most common mod temperature wax are Iowa wax and corrector wax, which are used for either for relining or for taking preliminary impressions. So, according to the ability of the set material to withdraw from the undercut, the second classification of preliminary impression or mainly impression materials is that based on their ability to be withdrawn from the undercut. That is, there will be elastomeric impression materials or rigid or non-elastomeric impression materials. In elastic impression materials, we have hydrocolloids, like I just mentioned, alginate. We have rubber-based impression material. The first rubber-based impression materials used in dentistry was polysulfide, which is also known as mercaptan rubber. And after that, we have agar agar, also known as reversible hydrocolloid, which is extracted from seaweed or sea algae. And we have silicones, which are broadly categorized into two types. That is condensation silicone, which you can see an example is the Zeta Plus putty, and the Ora Wash, which is a light body condensation silicone material. And this red tube, what you see, is the catalyst, which is used for both the putty and the light body to activate them. And the other type of silicone material, we have addition silicone. So this is again Elite HD, which is a putty, and this is what we use currently in our department. So after that, we have polyethers, which are also a type of elastomeric impression materials. They are unique in that they set by a ring polymerization reaction, whereas all the other elastomeric impression materials like silicones, alginates, polysulfide, they all are set by what you call as condensation or addition polymerization reaction. So in rigid, we have the impression compound and zinc oxide eugenol, which are now being used less and less in dentistry because of the advent of newer materials like agar and alginate. Moving on, coming to the types of impression trays. So, impression trays can be broadly categorized into either stock trays, which are prefabricated trays, and these trays may again be either perforated trays or non-perforated trays. Perforated rim lock edentulous impression trays are used along with alginate to record the diagnostic or preliminary impressions in complete dentures, and non-perforated trays such as these over here are used along with impression compound to take the diagnostic impressions. There are also a third type of rim-locked water-cooled impression trays, which are used with along with agar-agar for taking the diagnostic impressions. But off and on nowadays, the use of agar has decreased due to the requirement of expensive equipment, and takes a lot of time and is cumbersome. So, next, these were the diagnostic impression or preliminary impression trays. Now, the second category is also known as custom trays or special trays. These are fabricated on the models obtained from the preliminary impression. That is, first we take the preliminary impressions, we pour the diagnostic cast or primary cast, and on top of these, the custom trays are fabricated either with a polymethyl methacrylate, that's acrylic, or LC or light curable resin sheets. So, coming to the objectives of impression making, the objective of impression makings can be summarized by this acronym, that is PRESS. That is, first, the objective is to preservation of the remaining natural structure. The second objective, primary objectives of an impression, is to be able to create or fabricate a process which has retention, which is aesthetic, which is stable, and which has sufficient support from the dental bearing area. Now, moving on to the first objective, that is preservation of the remaining natural structures. Muller Divan famously said this statement in 1952, that the perpetual preservation of that which remains is of the utmost importance, and not the meticulous replacement of that which has already been lost. So, when a patient comes to you with all his teeth missing or some teeth missing, it is our duty to preserve what is left. Like if he has residual ridges, they should be preserved in such a way that the new denture will not damage them. That is, proper, accurate impressions must be made of the residual ridges so as to make complete dentures that do not further cause any problems. The impression should recall the detailed or in appropriate form to prevent the injury to the tissues. Relief, as you can see here, as I always tell you, a double relief should be provided over the incisive papilla, the mid-palatal raphe, and if you have extensively fibrous and prominent rugae over here. So relief by using a selective spacer is needed in the special tray or the custom tray to get accurate impressions for complete denture fabrications. You should avoid overextensions of the peripheral border areas. Coming to the second objective, which is the you make impressions. You do not take impressions in complete dentures or remove partial dentures. You make impressions with the primary objective to get a processes which is retentive. So, what is retention? Retention is a quality inherent in any type of processes which resists the forces of the gravity in a vertical direction, such as a patient may be chewing sticky foods or chewing gums, or the forces associated with the excessively wide opening of the jaws of the oral musculature. The denture should resist the displacement in a vertical direction, that is in towards the gravity. So this is basically what retention is. And the factors that affect the retention are, of course, anatomic, that is the size and quality of the denture bearing area. The larger the denture bearing area, that is in large jaws, the retention is better than in the smaller arches. Of course, physiological, that is the viscosity of the saliva plays a pretty decent role in the denture retention. That is, a thick viscous saliva offers poor retention, whereas thin serous saliva aids in the retention of the processes. Other physical factors such as adhesion, cohesion, surface tension, that these are all taking place between the tissues, the saliva, and the denture base. Adhesion is between non-identical molecules, that is between saliva and the soft tissue, and between soft tissue between the denture and the saliva. And cohesion is, that is within the molecules of the saliva. And surface tension, capillary and atmospheric pressure all play a significant role in retention. Others, things like undercuts and previously springs, magnets, suction cups, and use of adhesives also aid to a certain extent in the retention of the dentures, but these should not be the primary things that retain the denture. The last and foremost was something which was advocated as a neutral zone. That is, denture should lie in the zone between the cheek, the and the tongue and the oral musculature in such a way that it is not disturbing them, or it is in a neutral position, or it is in a balanced position between the cheeks and the tongue. And next objective was the stability. Stability is the quality of the denture to be firm or steady or constant. That is it. That is movement of the denture in the horizontal plane. That is in this plane is called as the stability. The denture should be able to resist the movements, the pressure from the tongue as well as the cheek. That is in the cheek we have the buccinator muscle, the risorius. So all these will try to push the denture in a lingual or in a buccal direction. So this is the ability of the denture to stay stable in the horizontal plane. And next, the factors that affect the stability are, of course, the vertical height of the ridges. Tall, rounded ridges will offer greater stability, whereas short or extremely poorly resolved ridges will offer no to very mild stability. The quality of the soft tissue, that is, if you have firm tissue denture bearing area, you will have a good stability. But if you have flabby or hypoplastic tissues in the over the crest of the ridge or in the vestibule, the stability will be severely compromised. Of course, the quality of the impression should be the brush should be accurate, smooth, and stable. The level of the occlusal plane also, to a greater extent, plays a role in the stability. If you have occlusal plane which does not comply or with the theories of jaw relation, then it may compromise the stability of the denture. And of course, the labolingual position of the teeth during teeth arrangement and the contours of the polished surface, that is of the palate, of the buccal and lingual flanges, is also responsible for the stability of the process. Now, coming to the next, that is the support. So support is the resistance of the processes in a vertical direction but towards the tissue. Remember, retention was the ability of the processes to resist dislodging forces in a vertical direction away from the tissues. Whereas support is the ability of the processes to be stable and retentive in a vertical direction towards the tissue. That is when occlusal forces are applied when patient clenches his teeth during mastication or any such thing. The processes should be able to resist these forces, and this is achieved by covering a large surface area. That is, entire denture bearing area or the basal seat area should be covered sufficiently by the denture flanges and the denture base to be able to have a good support, and this will help in dissipating and uniformly distributing the forces of occlusion, that is function and the function. So the last objective of the impression making principle impression making is aesthetics. The thickness of the flanges, the height of the flanges, the contour of the flanges should be such that they should support the patient's oral musculature. They should provide lip fullness. They should provide cheek fullness. They should reduce the nasolabial fold, and they should what you call prevent the commissures of the mouth from drooping downwards. So all this can be accomplished even in with a good secondary impression, because when you are recording a secondary impression or final impression, you're not only recording the contours or the height of the vestibule or the vestibular extensions, but you're also recording the width of the denture flanges or the denture borders during the impression making procedure. So, coming to the principles of impression making, first, that is more like fundamentals for impression making. The oral tissues must be in a healthy state. They should not be hyperplastic. They should not be oral stomatitis or dental stomatitis or any Candida albicans or any kind of opportunistic secondary infection. The tissues should be healthy and pink. The impression should include the entire basal sheet area, the borders of the denture of the impression, because they will ultimately determine the denture flanges in the complete denture. They should be in harmony with the peripheral tissues and the relieving structures like the buccal frenum, label vestibule, buccal vestibule, the hamular notch, the in the case of mandibular also the all these things plus the mesenteric notch, the lingual frenum, the mylohyoid ridge, the retromylohyoid curtain, all this should be taken into account. And universally nowadays we use the only acceptable method of taking impressions in a custom tray is a selective pressure impression technique. More about that later. And there should be sufficient tissue stops. A spacer should be provided in the custom tray with proper tissue stops and proper relief given over the anatomical structures in the denture bearing area. These are different type of spacer designs that you can see over here. The material that is being used to record the custom impression of the final impression should be dimensionally stable. That is why we use zinc oxide eugenol or a silicone, that is polyvinyl siloxane impression material in a custom tray. And the border molding is done using tracing sticks or grain stick compounds. For the all of these things, an intimate knowledge of the complete denture anatomical structures is required. So now coming to the classification of the impression making, that is, impressions are classified based upon the first is the different theories of impression making. That is, there are three theories of impression making. That is mucostatic, mucocompressive, also known as functional impression technique or functional impression theory, and the selective pressure impression technique, which is given by Baucher and which is largely followed all around the world. So, second classification of impressions is depending upon the mouth opening. That is how an impression was made, whether the mouth was kept open during the making of the impression and the operator was manipulating the lips and cheek, or the mouth was closed. That is the opposing occlusal rims or opposing dentures, opposing dentition was in contact with the impression tray, and the closed mouth impression technique was stable. Then, depending upon the type of the impression tray, of course, we have stock tray or prefabricated trays and the custom tray impression. And now coming to the classification of the impression, that is continuing the classification, and depending upon the purpose of the impression, we have primary or diagnostic impressions, which are taken with either with impression compound, which is a thermoplastic impression material in non-perforated edentulous stock trays, or we can use alginate in perforated edentulous stock trays. And the second type of impression is the secondary or the final impression, which is taken in a custom tray and generally with a green stick tracing compound and a zinc oxide eugenol impression paste. Coming to the mucostatic impression, as I said, mucostatic impression technique is in this, it is a pressureless impression technique. No pressure is applied during the recording or making of the primary impression. The advantage or the idea rationale behind it was that it led to the preservation of the tissue's health because no pressure was being applied and the blood circulation was not interrupted or hindered in the tissues, and it can be useful in flabby tissues or sharp spiny ridges or spicules because there is no pressure being applied, so patient will not have any pain or soreness of the ridges. But the disadvantage is that this type of impression led to a loss of the peripheral seal because there were short flanges in the denture, and more or less these were largely discarded. And for historical perspective, these impression techniques largely used impression plaster for impression making because in those times we didn't have alginate or agar. And the next, which was completely opposite, was the mucocompressive impression theory, which advocated that pressure should be applied during the process of impression making on the entire denture basal seat area. But of course, as we know now, that excessive pressure can lead to the blood circulation interruption and the resorption of the alveolar bone. It can hasten the result is resorption. Excessive pressure will lead to soreness in the denture base area, and it will result in soreness over the bony spicules and the undercuts. And because of the tissues will tend to rebound, and because they were recorded under pressure, this will result in the rebound or the lifting of the denture away from the tissue or the basal seat area, resulting in loss of retention. So the last and the most widely used technique given by Baucho was the selective pressure impression theory. So this combines the principle of both the mucocompressive and the passive impression techniques. In this technique, the idea is that we should is of tissue preservation and combining it with mechanical factors of achieving retention through minimum pressure, which is applied within the physiological limit of tissue tolerance on the parts of the residual ulnar ridge where the pressure can be applied. So again, as I said, we need to have a thorough understanding of the anatomy of the basal seat tissues and the surrounding musculature to be able to get a good selective pressure. So coming to the procedure itself, if we are seeing at the operator position for taking whether it be primary or secondary impressions, the operator should be standing for the maxillary impression, should be standing at the 11 o'clock position, that is just behind the patient on the right side. Whereas for the mandibular impression, the operator is standing in front of the patient at the 7 o'clock position. So there you go with the positions for impression making, and this will be the opposite for the left hand chair operators. And coming to the selection of the trays for impression making, that you take stock trays which cover the entire denture basal seat area, starting from the labial frenum to the hamular notch. There should be 2 mm of space between the denture borders and the vestibular depth, and the tray should be such that they should provide at least 4 mm of space for the impression material for recording the or making the impression, because if the space is less, it will result in the tear of the impression or the exposure of the tray. So moving on, so basically all of you know this. So when we are mixing alternate impressions, we take a curved spatula and a rubber bowl, and first the powder is dispensed and the water is dispensed after that in a 1:1 ratio, and the alginate is mixed using a curved spatula in a figure of 8 motion, and the mix is spread against the walls of the bowl to get a good creamy and thick viscous impression material. And then the impression is recorded, the patient in open mouth impression technique, and the operator performs all the border movements to record the border extensions of the impression, because having an accurate primary impression takes care of most of the work in a secondary impressions. If you do not have accurate primary impressions with the proper flange extensions and the proper recording of the denture base area, you will struggle during the final impression making, as I see most of you struggling day in and day out. So another material used for making diagnostic of primary impressions is the impression compound. As I said, this is thermoplastic impression material. We get impression compound cakes like this. These are then tempered in a hot water bath, and then they are kneaded into a ball, and which is then placed in the non-perforated Edentulous stock impression trays, and the impression is recorded. You have to move fast because it starts getting hard soon upon removal from the mouth. So coming to the disinfection of the impression after the diagnostic of the primary impressions, or any for that matter secondary impressions have been made, they need to be disinfected with a disinfectant solution, such as most commonly used is a 2% glutaraldehyde. You spray the impression with the glutaraldehyde and leave it in a plastic bag or a humidor for 10 minutes, after which the impression can be rinsed and the models can be poured. So this brings us to the end of this today's lecture. So I hope I was able to impart some knowledge to you guys, and that's it from me today.